problem was that when the Chinese patients show up at the hospital, they would tell us that they couldn't help this person because nobody speaks his language. So they decided they couldn't help immigrant patients. So I was shocked. I think we felt that there got to be a better way.
An idea that came up during dim sum in Chinatown with other, well, probably there are very few Chinese psychiatrists, so there may be another one, maybe a GP, a public health nurse, and a couple of social workers. So somehow we met, and then we had dim sum, and the idea came up from the stories they tell me. You see, I was working in a hospital, but they were working in the community, and they told me of the difficulties Chinese patients would face when they need mental service. But more so than the patient, the families have a hard time if they have a language barrier. So there were cases when a child, for example, was brought to the sick kid hospital, 9-year-old. They said, "We cannot serve you because we cannot talk to your parents."
But you've got to remember, 1970s, Toronto was very much unicultural. You know, we had Anglo-Saxon whites. That was the 1970s Toronto. So we felt maybe there's something we could do. But we didn't call it Hong Fook at that time. We just felt that we need to start a project. You know, from the first group of a ragtag mixed group of people, we were now talking about vision and mission. We had no idea of what we were doing. And we didn't know the possibilities. You got to remember we were a lot younger then. I was just starting my practice, and Dr. Low also, and so was Dr. Young. We were just greenhorns, you know, starting out. So we basically didn't know what we were doing, but we just felt that something got to be done. We sent in our proposal, I think fairly early in 1975 or 76, but it was collecting dust in somebody's office. Nobody looked at it.
We applied 4 times, and the reason we succeeded on the 4th attempt, I believe, is we should thank the boat people. That is, the people, refugees coming from Vietnam in droves at that time, and Canada has been particularly, welcoming. So a lot of them came through Vancouver and other places, and a lot of them settled down in Toronto. At that time, the first batch of the refugees were ethnic Chinese, actually. So I think the thinking of the ministry at that time is it would represent part of the government's effort to help these folks.
So then somebody discovered a Hong Fook proposal on the shelf. I think it was on the shelf at the right time. Suddenly they needed something for the mental health services to the refugees. So that's what they wanted us to do, to service the refugees. So our early populations were Vietnamese, Cambodian, and Laotians. And we say, can we also include Chinese? There are a lot of Chinese immigrants in those groups, refugees. So we had Chinese and the Southeast Asian countries.
A lot of people would think that if you want to provide an ethno-specific service, then you have doctors, nurses, and social workers, and then provide direct service to these people. And we actually did not plan that way. We were actually inspired a bit by the consultation liaison model in General Hospital, and also some of the somewhat similar initiatives in the community, in that we want our staff to be brokers. Our workers try to help the client in all aspects of their life, and not just seeing doctors, which other people would have interpreters do. I think that made a lot of sense actually to hospitals. In fact, one of the chief of the biggest hospital here was telling me when we introduced the service to them, they said, now mind you, that's over 30 years ago, and before case management became a model that is commonly used in community psychiatry. So there was no such term as case management. But what we did was actually case management. So he said something very interesting. He said, oh, wow, that's a very good service. I hope we have that for our white patients.
The group of us actually called up hospitals downtown saying that don't turn away Chinese patients. If you need help, we come.
We talked to local hospitals to arrange our workers actually to spend half a day there, so that they can pick up referrals and help their clientele, who may be Chinese and Vietnamese at that time. That experiment did not last too long. After a year or so, we took our workers back. Because having a single worker there, even though their physical presence once a week was not really enough of an impetus to cause any increase in referral or other things. Basically, it's an idea I think the hospitals are not used to. They are used to do everything themselves. So to be able to consult with other people and use other resources outside the community is not something that is makes sense to them, maybe. I mean, they agree with it, not that they are supportive, but they don't know how to do it.
So one big challenge is financing. The second challenge is finding the right people. Because at that time, the number of professional people available from the Southeast Asia were rather few. Cantonese speaking was no problem, because from Hong Kong you had professions of every kind. You have social workers, you have doctors, you have psychologists, psychiatrists, So Cantonese speaking professionals that you can recruit was okay. But then shortage of funding would limit the number that we could hire. With the Southeast Asian community, the problem is the other way around. Not that we had too much money, but then it's hard to find people, even when we had a budget funding for one position. To find somebody that's really trained to do mental health work was difficult. So we sometimes co-opted teachers, for example, school teachers, since we don't have social workers and psychologists, so we people who were school teachers in Cambodia, for example. So they came and could be retrained to do the kind of work that become mental health workers at Hong Kong. In the 1970s, mental health was still a poor cousin. The people had trouble talking about having mental health problems. So that to go to a community and say that, oh, we are a mental health agency, we want to work with your community, and the response was that it's not a problem in our community. We don't have anybody who have mental illness. So the initial contact is always denial. So we don't need you. What are you suggesting? You're suggesting we're crazy or something? So basically, the initial contact can be very negative.
Our first offer to the community was a session on mental illness. So we debated on the topic, and we chose a topic, say, are you crazy? So we chose to confront the issue rather than cover it like emotional mental health or something like that.
The more we talk about it, then it became okay to talk about it. But if you don't bring up the question, they just keep hiding their sick people and won't get help.
We've been quite involved with the media, with even last year, a TV series that we sponsored, which got our phone ringing, non-stop. And this has, over the 30 years, established Hong Fook as something that the community knows about, and people usually come to us now by self-referral, meaning that they are not referred through the medical system or the mainstream psychiatric system. They do come from those sources too, but the majority are self-referrals. People just pick up the phone to call, or they heard from their friends that there is such resources to help them.
And in fact, Hong Fook grew rather rapidly from a beginning of 1.5 staff to about more than 60 staff now. And we started with one table, one chair in the corridor of Cecil Street Community Center. That's how much money we had for. And now we have 3 offices, one downtown, one Scarborough, one in North York. So I think within 30 years it evolved. And for a rather low-profile specialty, because psychiatry was never the sexy specialty. It's unlike heart and stroke and cancer, and these are big guys. But for mental health and culture-specific mental health, we were not on anyone's radar screen. So we just worked away in our own offices and tried to expand our services to wherever they're needed.
We started with Chinese and Vietnamese, then we expand to Cambodian and then Korean. And even with the Chinese, the waves of immigrants are different now. The early bunch were from Hong Kong, Cantonese speaking, and then now the majority are from mainland China, Mandarin speaking. And then of course from Taiwan, there are also immigrants who are Mandarin speaking but have quite a different culture from the mainland Chinese. So in a way, there are different cultural groups that we are expanding to, and hopefully I feel that we should expand to a few more. It's not empire building. It is the fact that after 30 years, no other ethnocultural group has been able to establish a mental health service for their own people. Shows how difficult it is, or how lucky we are in that we have done this. So I think we'd like to help other communities to develop such services.
Well, the way Hong Fook grew, I think, speaks to the need for mental health services within our communities. If you want to start a project like Hong Fook within your own community, the important thing is that you've got to believe in it first. You cannot sell something you don't believe it yourself. You can't sell a product you're not going to use yourself. So the first condition would be that you've got to believe in it, and you've got to be persistent, because you have to spend time on it. It's not something that would have an overnight success, and you're going to overcome various resistance in the community. We ran into that with the stigma and the people opposing housing in their community. So just like any other mental health groups, we cope with it. We encounter the same kind of community reactions. You've got to be willing to work with the local population. Otherwise, you can't survive.
For anyone who has an idea to develop ethnospecific service for their community, I think one is that they have to have passion and endurance, and then supported by critical mass of like-minded people. Now that actually is a very important piece. I think we started with a group of maybe 5-10 people, and if I were alone, I wouldn't be doing this. And the fact that there are people who share that and support one another is the only way that you can get through it. I think there are certain things that really are unique and which I enjoy, and that's why I am still involved after 30 years. One is that it's community-based. It's not just physically based, but like I told you, by involving ourselves with the media and other things and having people come in directly to us, all those makes us part of the community. I think that is attractive. And the other is the staff who come here, would get better pay if they work in the mainstream hospitals. So one of the things that attract them to come here is that they do want to contribute to their own community. And that draws a group of like-minded people who share this passion. And that's very attractive. And so that's why I got these psychiatrists to come for half a day, one day. Aside from their involvement in the hospitals or the universities, they still come here because they like this contact with the community and with like-minded folks like us. Because the bicultural mental health professionals, I think it's a very special group. A lot of them submerge their own cultural identity to fit into the bigger mainstream system. And it's a shame. I think being able to realize your own identity and how you can express it is a much more balanced career development. Not just career, but your personal development.
The one great advantage of working with Hong Fook was the kind of people you meet there. I had a chance of meeting wonderful people who are dedicated, who really believe in what they're doing, who has a mission, and the pleasure of working with such a diverse group of people.